Hi guys, um, I hope everyone is doing great. This is Dr. T, and this is Clinical Medicine with Dr. T. So guys, I haven't done a video on a patient that I saw for a very long time. So welcome to today's episode of a patient that I saw. Um, a patient that I saw. So for those who don't know, in this feature, whenever I run into an interesting patient in the hospital that I think that we can learn something from, I always just note a few things about that patient, and then I come and discuss that patient. So for today's discussion, today I saw a 14-year-old female 14-year-old female patient that was coming from home with a history of urinary retention. So I'm working in casualty right now, and we deal with medical emergencies, and everyone knows that acute or just urinary retention is seen in A3, which is like more of your trauma side, trauma, abscesses, retention of urine. When I was working in A3, I used to see a lot of urinary retention patient, especially your BPH, your say prostate patients, your strictures, that kind of a thing. So, so when I saw this patient, she came in with, she was accompanied by her mother. They came to casualty. And then when I was listening to what they were saying, retention of urine, the chief complaint, I was like, okay, let's go to A3 where you're gonna get help. So in my mind, I was gonna hand them over to a doctor there and then go back to casualty. But as I entered A3 walking with them, I was like, this is unusual. 14-year-old female with retention of urine. Let me see this patient for learning purposes, and also just to see what's really happening with this patient. It's very unusual. Like I'm saying, a lot of cases of retention of urine. So the main complaint was retention of urine. And the duration was, so she hasn't passed urine for the past 4 days. For the past 4 days. And like I'm saying that we are used to seeing retention of urine in the hospital, and the most common causes of retention of urine that we see is patients with BPH, patients with CA, prostate, patients with urethral strictures. Urethral strictures that can be due to previous urinary catheterization. We also see a lot of like previous pelvic trauma. So those are the most common causes of retention of urine. I can't think of any other at this point, but those are the most common ones. But now, if you look at the age, okay, previous STIs in males, previous STI or male urethral syndrome as they call it now. So those are the most common causes of retention of urine. So, but if you look at this one, it's a female first of all, and retention of urine is not very common in females in general, especially not at that age. So I thought to myself, this is interesting. Let me see this patient myself. So I saw this patient in A3. So I moved with the patient to A3 and I saw the patient in A3. So this was the only presenting problem. I asked about burning of nutrition. There was none. I asked about increased frequency of urinating. I asked about UTI symptoms. She didn't have any of those. No UTI symptoms. And then I was like, okay, let me inquire now about sexual history. She was not sexually active. She looked so innocent. She was not sexually active according to her, and I even asked the mother if she has not picked up any problems, maybe abuse or any, maybe the child the child now is starting to have sexual intercourse. She was like, no. So, and I was thinking, okay, what could this be? I asked about other symptoms. This was the only problem that she had, according to him. She was eating, no history of nausea, no history of vomiting, no history of PV discharge. No history of PV discharge. And there was no history of trauma, like falling or being kicked, things like that. It was getting more interesting and at the same time a lot scarier, because now I was not finding anything that I could work with. And then I was like, okay, so past medical history, she was not on any treatment, but RVD was not known. No past surgical history. It's been a child that has been previously well, eating, going to school, playing with other kids and everything, and all of that. So I was like, okay, let me go into the gynae history. So when I went to the gynae history, I asked about the only thing that I asked there. Obviously, there was no sexual intercourse, so he had no history of sexual intercourse. So at that time, there was no history of menarche as well. So this little angel had not even gone for a period. Okay. Obviously, there was no obstetric history there. Okay. And then I was like, okay, let me just do examination. She looked well. She looked well hydrated, not ill looking. She was well built. All her vital signs were normal. And then I did a abdominal examination. There was suprapubic distension. Suprapubic distension. But there was just mild tenderness when you press. I think since the bladder was full, so there was a bit of tenderness when you press on it. But the abdomen was generally soft and non-tender. There was no messes that I could palpate. The liver was fine. The spleen I couldn't palpate the spleen. So I didn't pick up anything except a distension or a mess in the suprapubic area, which I thought was a descended bladder. I don't. So as I was thinking, I was like, when was the last time you went to the bathroom to pass stools? She was like, it's been a while. I said, okay, try to think. I said, was it 2 days ago? No. 3 days ago? No. 5 days ago? A week ago? So eventually she was like, I think it was, I've not gone to the bathroom for the past 2 weeks. Yeah. So when she said that, I quickly asked her, I was with the students. I think they thought that this guy is crazy. So I did a PR. When I did a PR, there was, the rectum was full with stools. It was like full with stools. Such that, I love when I do a PR exam, I enjoy doing a PR and come out with stool. This thing of coming out with a clean finger is not very, I don't enjoy doing it. So I came up with a lot of stools when I came out, which were normal in color. So at this point, I was like, this kid must be having chronic constipation that is causing urinary retention. I've never heard of that anyway, but I put my money on that. So what I did is, so my assessment was, constipation with urinary retention. Because I mean, you could examine this kiddie the whole night. You wouldn't pick up anything. I didn't pick up anything. Lymph nodes, nothing. I didn't pick up anything. So what I did is I sent her for an abdominal X-ray, and on the abdominal X-ray, I'm gonna show you guys at the end of this start. I'm just gonna screen grab it and put it there. You're gonna see it for yourself. Like, she had massive stool infection. Ascending colon was full of stools. The rectum was full of stools. The descending colon was full of stools. So I was like, this is interesting. This is very, very, very interesting. So what I did, is, I was like, okay, we need to remove that. As much as I did educate now the mom that this kid needs to drink a lot of water, have a lot of fiber in the food and all those things. So what I did, I wanted her to get a relief. So I did an enema. I used tap water, and then I used a cannula, and that water was about a liter. The water that I used, 1,000 mils. So I took tap water, and then I took a 20 ml syringe, and then I wanted to flush the rectum and the colon with water. So I put about 1,000 mils of water in the rectally. So I pushed in water there. So what I did is, I took a green cannula. I removed the needle part, and then I was just left with that with the plastic part of the cannula, the one that we always leave after getting a line. So that's what I left. So what I did, I used that to suck water using the syringe, and then I just pushed water into that rectum, about 1,000 mils. And then also after doing that, I prescribed for him liquid paraffin. Personally, I find that lactulose is not very potent. I don't know. I prefer liquid paraffin. So I gave the patient liquid paraffin. And then after that, this patient was already going to get medication, but I was like, I'm forgetting something. So I went to call her. And then what I did, I passed a catheter, which drained about 1,200 mils of urine from the bladder. So I wasn't so confident to come and tell you guys about this patient. So what's gonna happen is they're gonna take this medication. The liquid paraffin, I prescribed it for 5 days, and then I wanted them to come back again in about 2 weeks' time. And then I advise them to take a lot of water, take a lot of fiber, and then come back. If this thing does not clear or it recurs, she might need to be referred to maybe gastroenterologist to find out what else is causing this. But for now, this is what I did. So I wasn't so confident to come and talk about this patient because, like I'm saying, this is a very uncommon and atypical presentation of constipation. So when I came back, I just looked for an article, and it is in literature. Yes, they say it's not common, but it is there in literature. So their explanation is that, remember, the rectum, the vagina, and the urethra are very close structures. That's why you get those fistulas in gynae, those gynae fistulas between those openings, between those three openings, or those three, whatever, compartments, whatever. Between those, you can get communication because they're very close to each other. They are very, 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 very close to each other. So the explanation is that constipation can be so bad that it displaces the entire bladder, and once it displaces the entire bladder, it obstructs the opening or even the urethra itself, and then that's how you can get retention of urine. Yeah, guys, so that's what happened today. It's an exciting patient. It is really an exciting patient to talk about. And yeah, thank you so much. That was a patient that I saw, which is today, the 22nd of June 2021. Thank you.